Welcome to our Ask the Experts. Here we are at the end of September, which is hard to believe. And we have been very active, just bringing a lot of content to you this month. It is, as we know, Ovarian Cancer Awareness Month. And we always like to share an additional lens on this month and talking about really popular topics that are front of mind. Some are new to our community, and some have a lot of questions and concerns. So today we're very excited to bring to you a topic, ADCs, which are antibody drug conjugates that allow us to talk about that and ovarian cancer and how they relate to each other. Before we get started, I always like to thank our sponsors because we just cannot do what we do without them. So our education sponsors and our events are brought to you by West, Merck, and Daiichi Sankyo. And we have additional support from Lilly, GSK, Gilead Sciences, Pfizer, and Immunogen, which is now a part of AbbVie. So we're very grateful that they continue to invest in Unite for Her, continue to do all of the good work in order for us to do over 40 of these live segments a year and really see and trust the mission that we are able to deliver to our community. So thank you for all of their support. Okay, now for our guest. We are so honored to bring to you front and center our guest for today. So welcome, thank you for being here, Dr. Leah Moukarzel. She grew up in Philadelphia area. She attended Haverford College, where she received her Bachelor of Arts in Political Science and a minor in Spanish. She received her MD from Jefferson Medical College before it became Sidney Kimmel Medical College, and completed her obstetrics and gynecological training, residence training at Johns Hopkins Hospital. She went on to complete a 4-year gynecologic oncology fellowship at Memorial Sloan Kettering Cancer Center. She is currently a gynecologic oncologist at Abington Jefferson Hospital. Her surgical interests include fertility-sparing surgery for advanced and recurrent ovarian cancer. So please join me in welcoming our expert today, Dr. Leah Moukarzel. How are you? Nice to have you.
Thanks for having me.
Got it. Thank you for joining.
So this is just so exciting. Yeah, it's an exciting topic.
Yeah, I know we hear so much about new targeted therapies, and it gives so much hope to our community, Dr. Moukarzel. So I just want to dive in. We have a lot of questions that came up ahead of time, and it can be complicated, especially when you see all of the abbreviations, right? And ADCs, and you're looking at them and going, okay, what does that stand for? And what are we talking about? And it's a lot for our patients to actually navigate, right? So we felt like our first one to just get started is give us the ABCs of the ADCs. If you could start there, amazing.
Great. Yeah, and I just want to I hope this topic also brings patients a lot of hope, because we really haven't seen this is like an incredible era to be a GYN oncologist and see these advancements. We'll talk about it some more, but we'll talk about the side effects and everything, but it's really just a wonderful new option for patients. And so really what ADCs come down to, just to understand it plain and simple. So A is for the antibody, D is the drug, and then C is the conjugate. So it's a drug attached to the antibody. And so the idea behind it is that it targets cells, it gets internalized into those targeted cells, and it's more precise. And so we try and avoid general chemotherapy that just targets all rapidly dividing cells, and this is more targeted. And so just to explain it a little bit more, so it's an antibody, you see the little Y, and it connects onto these receptors. I kind of think of it as a key. It finds its perfect keyhole. And what the antibody drug conjugate is, so you have the antibody and then you have a linker, which I kind of think of as like a grocery bag. And inside that grocery bag is your cytotoxic agent or your chemotherapy. So it's the antibody with a little bag, and inside that bag is the drug that you want to deliver. Instead of giving that drug to everybody or all the cells, that antibody then hits a certain receptor. And so we're trying to optimize the best receptors. And once it does that, the receptor takes it into the cell, it kills that cell off. And then that's the idea. Then some people kind of think about it as the Trojan horse. You're hiding your drug within the horse, and then you get it inside, and then you explode the cell from inside out. And when we think about cancer drugs, we think about a therapeutic window. And the more we can optimize that therapeutic window, usually the better the survival benefit. And what the therapeutic window is how much can we maximize the drug with minimizing the side effects? And ADCs have proven to really be the first time we've really been able to expand that window because it just selectively targets this tumor cells. So that's the concept behind them. I hope that clarifies it a little bit.
Such good analogies. Thank you. And they are available not just in ovarian cancer, correct?
Correct. So they actually started way back in the 1990s. They started in hematological cancers, where they started to be used. So they're not completely novel. The advancements in them and the advancement in using them in solid tumors like ovarian cancer, cervical cancer, breast cancer, that's what's happening. But I really think we're just seeing the tip of the iceberg. We're really just starting this process.
Yeah. Well, we had quite a few questions come into the audit from our audience, and one of them was, is this a type of maintenance treatment? So how long are you on these ADCs?
It's a great question. So right now it's approved in ovarian cancer, it's approved for the platinum resistant ovarian cancer patients. So usually you've already seen your platinum, your backbone of chemotherapy, and either the cancer has progressed or come back. And so it's not necessarily a maintenance, it's therapeutic where we are actively treating, but you stay on it until either resistance and the disease starts progressing, or the toxicity is limiting, and then we take it off. So you can think about it as maintenance in the sense of usually patients are on this for a long time, but it's a therapeutic treatment.
Okay. And then there's a couple different types of ADCs. Are there specific names that you come across that our audience should be aware of? Like, is Avastin one of them?
That's a good question. Yep. No, so Avastin is bevacizumab, which is not an ADC. It's anti-angiogenic. That actually targets vascular growth of blood cells. It does not have that antibody attached to a shopping bag with some chemotherapy in there. It doesn't have the linker with the cytotoxic agent. It just has a specific target. So Avastin is not an ADC.
Okay, thank you. That same individual was also asking, when do ADCs get introduced into treatment?
So currently, based on FDA approval, we're doing it in the platinum-resistant disease setting. There are current trials that are open looking at using it in platinum-sensitive, but you have to be on trial for that. We have that trial open. I have a few patients on that trial. And the way I explain it to patients is very often when a new drug comes into treatment of cancers, it often starts up in the recurrent, way out in the recurrent. You've already seen 3-4 lines, and then it slowly moves up. If it's a good drug and we see amazing benefit from it, we're going to try and use it earlier and earlier and earlier. So currently, unless you're on a study, it's being used sort of for the more aggressive situations, but I do see it moving up and becoming part of our upfront treatment.
Okay, and it is in combination with chemotherapy, correct?
So at this time, it's not yet. So you've already gotten your chemotherapy, you've progressed on your chemotherapy, or you've recurred, and then we just give you right now, mirvetuximab, which we'll talk about, is the only FDA-approved ADCs. There are a lot more ADCs. Okay. But you'll hear mirvetuximab over and over again because that's the only one approved and the one being used the most because we have good phase 3 clinical trial data on it. And currently it's approved to be given in the recurrent setting. We do sometimes, certain physicians will give it with Avastin or bevacizumab because there's some phase 2 data to say that in conjunction there is additional benefit. But that's definitely something that's being investigated. The next, really one of the big questions left is, now we know that it works. Well, what can we add to it? We're even going to try it. There are studies trying it with immunotherapy. Should we try it with chemotherapy at the same time? Are the side effects too hard if you put it with chemotherapy? I don't see it probably being used with chemotherapy because the concept behind it is that you are administering chemotherapy. You're just administering it precisely. I think if we're going to add things to it, it's things like immunotherapy,
Okay,
bevacizumab, other drug types.
got it.
Good
Now,
questions.
you were talking a little bit about side effects and symptoms. Can we move into that? Can you tell us about the side effects and symptoms of,
Absolutely. Yeah.
yeah, the
So,
ADCs?
okay, absolutely. So, first of all, you might ask yourself, like, why are ADCs causing side effects, right? So the concept behind it is that you're targeting just these cancer cells. Well, why, we shouldn't have any side effects then. So just to explain it a little bit, and because I think we'll understand where things are going. One thing is that linker, that shopping bag that attaches to the antibody. Sometimes it weakens and it lets go of the cytotoxic agent before it's at that target, before it's even gotten to that cell, just from just being in your bloodstream, wherever it is. So we're looking at using different types of linkers to attach it that might be stronger, that might be, work better. So that's one of the reasons we get the side effect. The other thing is, even once it's internalized into the cancer cell and it releases the chemo in that cancer cell, well, sometimes that chemo can then diffuse out of that cancer cell and hit the cells nearby. We actually like that concept partially because usually it's other cancer cells that are nearby. Sometimes it's cancer cells that don't express that receptor, so it's actually good. It's attacking more. It's called the bystander effect. But sometimes those are normal cells. And so that's another reason we might have these side effects. So we're working on improving all that. But because of that, one of the main side effects is it gets into our tear films and also maybe through our bloodstream. It's not quite clear how it gets there, but the thought is mostly through our tear films. It gets into our eyes, and the tear film sort of lines the outside of your eye, and the cornea, which is the area that covers the iris, your colored, and your pupil. When you have dry eye in general, that's the area that can get sort of irritated. And so the drugs make it to that area, and it can cause dry eyes, blurry vision, and then it can cause something called keratopathy, which is sort of, if you think about like an abrasion and you get a little scab, it can cause a little bit of that. That's definitely, at least 50%, a little bit less of patients reported some form of blurry vision from the drug. And then some other side effect profiles, some peripheral neuropathy, diarrhea, some abdominal discomfort. But I will say, and we'll address it, if you compare it to chemotherapy, it's not perfect. It's far from perfect. But we wouldn't be able to keep a patient on chemotherapy for the amount of time we're able to keep a patient on mirvetuximab, for example. So overall, the side effect profile is much more, you can live, you can do your activities of daily living, or we try to, always make sure to touch in with our patients and adjust things if that's not where we're at. But the thought is that you are able to maintain your life with these drugs on board that you would not be able to do with regular chemotherapy.
Great. I know you were talking too with some of the older patients that get cataracts. Can you sort of talk about that a little bit?
Absolutely, yes. So what I've noticed from personal experience, the studies did not look at the rate of cataracts, but it's been reported in the literature that many patients have reported increased cataracts while on the mirvetuximab. And sometimes that actually it's not a bad thing because it's treatable. And often I've had 2 patients thus far get their cataracts removed with drastic improvement in their vision, in their vision. They had underlying cataracts. It didn't cause the cataracts, but it's just once you have the cataracts and you have something else superimposed on it, the two together just make the vision that much worse. Where if you can alleviate one problem, a lot of patients feel drastic relief of their symptoms.
Great. Thank you. I think it's so important to be upfront with the side effects because once we know where they are, then we can manage them, right? We can have a plan. If you don't have a plan, then you feel like you're blindsided, right? You don't understand how this all happened if you weren't aware of it. But if you have a plan and your doctor's walking through that, then that's really hopeful that you can be on this treatment for a longer time and it's targeted as well.
Yeah, and
Yeah.
we with the eye toxicity, because it is concerning. It's overwhelming for patients. It's a new side effect that we're not used to with chemotherapy. So we do request, a baseline eye exam, and then you get an eye exam every other cycle. And then your ophthalmologist or optometrist, actually, there's a form on the mirvetuximab website or that they fill out so that there's very good correspondence with the oncologist as to what is the progression of the symptoms. And then we can then act on that and decide, do we take a little break? Do we dose reduce? Do we try to go for cataract surgery? And so we try and really establish a good communication. So it's not on the patient to feel stressed. Oh my gosh, I can't see all of a sudden, but it's really important to have a good communication with the eye care provider. Absolutely.
Yeah. And I love that you have options as well. You talked about dose reducing. Have you seen any of your patients dose reduce and then those side effects alleviated and the outcomes and the efficacy were the same?
So I had a patient who also had significant diarrhea, and she was actually on the mirvetuximab with bevacizumab. So Bev can also cause diarrhea. So I took we took a break, and I stopped the Bev, and I just continued the Mirv. And when I did that, both her diarrhea improved, and then that break allowed her eye symptoms to improve. And then she's going for cataract surgery actually in about 2 weeks.
Okay.
So I haven't had to dose reduce yet. There's actually something else I would like to mention that's very impressive. It's really important to note that these eye toxicities are reversible. There are many things in side effects from our chemos that really put a long-term detriment on us, whether that's neuropathy or, your bowels, but these are reversible. So I don't want patients to be scared. Even the worst, there was one patient on the trial who had grade 4 complete keratopathy. They stopped the drug, and in 15 days, it all resolved. So just
Very
a
hopeful.
little bit of reassurance.
Yeah. Thank you for that. One of the questions is why is folate receptor alpha a good target in ovarian cancer worthy of this exploration? Can you explain that a little bit for me?
Yes, because that's the target for mirvetuximab and one of the main ones that's being investigated. And the reason is, so it's very highly expressed in ovarian cancer cells. About 80% of ovarian cancer cells will express this, and it's not highly expressed on normal cells. So that's number one. The second thing that they found is that the expression is very stable over time. So it's not like we start treating and then the expression goes down. Now, you can develop resistance, which we are still investigating, but the expression level, you don't go from a 75% expression to 45, you stay sort of stable. And so as a provider, you're not concerned, so those are two of the main reasons we really like it. And we've put a lot of time into investigating it as an option.
Yeah. And then there was some questions about clinical trials, looking at this. And did you see any clinical trials that have been effective, and what did it show?
Yes. So for the MIRV, there's about 3 drugs right now that specifically have looked at folate alpha receptor. So it's not just mirvetuximab, just so everybody knows, but that's the only one that has made it all the way to a phase 3 trial. But we do have phase 1, phase 2s on the other ones, but not spending time on those. I will say the big one was the Moukarzel trial, which looked at mirvetuximab. Phase 3, meaning that that's when we finally know the dose, the safety profile, that it has an effect, but now we compare it to standard of care. And that's what that trial did. Patients either got the MIRV or they got the chemotherapy. And it was about 500 patients across 21 countries, a really well, designed trial. Half of them got the drug, the mirvetuximab, half got standard chemotherapy. And what we learned is, and I have to clarify, platinum resistant ovarian cancer, and in high expression tumors. So from the phase 2 studies and from a prior phase 3 study, we learned that at least for mirvetuximab, the impact is really in the high expressing tumors greater than 75%. So the Moukarzel trial really focused on these high expressing tumors, and they saw a response rate of around, high 40s. And that's compared to your standard chemotherapy, which was around 15%. So you're talking more than a double improvement in response rate compared to those standard chemo patients. So improvement in survival, improvement in response. And then that was published in the New England Journal last year. And then the FDA approved it officially in March of this year.
So good.
Yeah, incredible work.
Yeah. So where do you see the future of ADCs?
So mirvetuximab, folate receptors, I think we are going to start targeting a lot of other receptors. There was a really exciting trial that came out last year for us where it's the Destiny trial where, for example, we targeted HER2, a very well-known target in breast cancer. It's made its way in endometrial cancer as a target as well. And now it was a basket trial, meaning that it looked at many different types of cancers, but there was a good amount of ovarian cancer in that trial. And when you looked at those that expressed HER2, it was a phase 2 study, so it wasn't comparing it to your standard, but the response rate were in the 40%. And then if I recall, it went up if your expression was high of the HER2, it went up to about 50%. If you've only received one prior line, it was as high as 60% response rate. I mean, just
wow,
incredible response rate where I don't know that for platinum resistant, the last time we saw progress was over 10 years ago when Bev was introduced. Since then, we really haven't had anything new to offer our patients. So I do see that as a future, new receptors being targeted, like I said, new attachments, linkers that are better, stronger, that can cause less side effect profiles. We also need to start targeting tumors that don't necessarily have high expression of these receptors. So we need to start looking into that. Just the way, with PARP inhibitors and HRD, what if you're not a high, now we need to see how can we make it strong enough to help people who aren't high expressors of that. So that's probably where the work is going to focus on.
Yeah, it's so hopeful. Dr. Moukarzel, is there anything that I missed that you might want to, share with our audience that is really important?
I think we've touched on most of the main topics about it. I think that precision oncology, as we call it, is really the future. I think we're going to stop one day treating cancers based on where they originated. We probably won't call it ovarian cancer one day. We'll probably call it a folate receptor expressing tumor or HER2 expressing tumor. And that's incredible. It's incredible advancements. It's an exciting time to be in the field. And for patients, I think I have a patient personally who, prior to mirvetuximab, she's not just platinum resistant, she's actually platinum refractory. And she's been alive now for over a year on this drug. And it's been amazing to be able to offer that to her. So lots ahead. Lots of good work.
No, it's so good, especially in this ovarian space, right? And that's what we're so excited to see. I've heard that several times when I've been on panels or at conferences where one day we're not going to be calling the cancer after the body part. And that's progress, right? Because you're getting such precision medicine and targeted treatments. I'm 20 years as a survivor. So much has changed. So much it's a whole different language, right? A whole different language, and see how far we've come. And so it is very exciting. I appreciate your insight. It really allows a lot of our ovarian community and our breast community to see the hope and see the future. And thank you so much for being here and explaining a very, sometimes complicated topic, right?
Yes. I know it's a lot to explain, I always tell patients, when you go home, write your questions down because it's getting more and more complicated. It's really, come in with the clarifying questions that you need. It's confusing. It takes time, multiple conversations. Don't be shy to ask.
Yeah. And I think too, the bottom line is that the side effects are moving to a better
Yes,
place for our patients, our community, compared to
absolutely.
what chemotherapy was. And that's the movement, right? So it's not perfect, like
Not
you said, but you can sustain and actually stay on treatment. And that's always the goal, is to be able to stay on treatment and have a good quality of life, right?
absolutely.
Yeah. Well, thank you so much. We appreciate you, and just so glad you took this time out of your busy day, because I know how your Thursday can be. So thank
Yes,
you.
thank you. Thank you for having me.
Oh, you got it. All right, everyone. Well, thank you so much for joining our Ask the Experts. I'm so grateful that we had Dr. Moukarzel here to share and walk through the ABCs of ADCs. The acronyms can sometimes trip us up, but know that we can look at this recording and really get a little bit more information. And I love the analogies. It allows us to sort of see firsthand that precision medicine and how it's truly targeting the cancer and not the whole body, and really appreciate all of that insight. Just as a reminder, tonight we have another Her Speaker series, and it's on Zoom, and it's at 6 o'clock, and it's lymphedema and ovarian cancer with Dr. Tommy Buchanan from Abington. So please join us tonight. Aubrey is going to be the host tonight. And then they're also going to have physical therapists on from Revital Cancer Rehab. Again, everything is on our library. So much information there, incredible resource for you, uniteforher.org/her library. And then we want to thank our sponsors one more time. So our lead sponsors, again, are West, Merck, and Daiichi Sankyo, with additional support from Lilly, GSK, Gilead Sciences, Pfizer, and Immunogen, which is now a part of AbbVie. So thank you all for joining us. My name is Sue Weldon. I am the CEO and founder, and it was my honor to be able to have this Ask the Experts here with all of you today. Have a good day. Thank you.